So I just want to quickly show you some of the pathways that we have that are live. So on the left-hand side, you've got your contents, and if it's grey, it means that it's a pathway that's not yet developed for Sydney North. So you'll get a warning that it's not yet adapted for Sydney North, and it's just the original Canterbury pathway, which may be useful to you, but it's not going to have the appropriate referral pathways for our LHD. So I'm just going to show you the medical and diabetes ones. So we've only got, we don't have everything live as yet, but we've not done too badly since Health Pathways went live in May. These are all the pages that are active and available for diabetes. So in each item, you can just see that you just essentially keep clicking on what's relevant to you. I just want to show you, for example, medications. So say here, medications in diabetes. So if you're thinking about, okay, what am I going to use for my patient? Apart from metformin, you can click on other glucose lowering agents. And if you go down the bottom, I like expanding all the drop downs so you can see everything that's on the page. And you can go through, so some of the pages have red flags at the top if they're more clinical things. But here, this has a list of all your medications that are used in diabetes and side effect profiles and which patients it would be useful in, precautions, and it's all there on the one page. Or you can not expand it and just pick whichever drug group you want to go to, for example here, SGLT2 inhibitors. And I just want to draw your attention to what they call diabetes requests. That's the terminology that was used with the original Canterbury Health Pathways. So even though we would prefer a terminology like referrals or something like that, but diabetes requests basically means your referral pathways. And so for example, if you wanted to work out where you would send your non-urgent complex diabetes patient for a specialist review in our LHD, you can go to this page and it will show you what's available for the different services that are in our LHD. Okay, does anyone have any questions? Otherwise I'll move on to talking about diabetes complications. So I wanted to focus on microvascular complications, and I hope that's okay with everyone. So because we do have a lot of practice nurses here, and my approach to diabetes, well, type 2 diabetes, is that a lot of it should really be managed in primary care and by general practitioners, unless it's something complex that needs an urgent review and needs some sorting out, or if there are complications related to diabetes that need to be addressed. And then once those things are stabilised, then patients should really be thereafter managed in general practice. And I think it's fantastic that some practices do have practice nurses, where a lot of diabetes work can be taken on by practice nurses, and I think you should make sure you're utilising your practice nurses in that way. So, microvascular complications. It's relevant because we advise our patients about controlling blood glucose levels and guide them with managing glucose levels for the main purpose of preventing complications from arising. And it's clear that improving glycemic control will reduce the risk of microvascular complications in type 1 and type 2 diabetes. So diabetic neuropathy specifically does increase the burden of self-care for patients, and diabetic foot ulceration, which Ian will talk about further, is a leading cause of hospitalisation for people with diabetes. So it's a big cost to our health system. Diabetic retinopathy causes visual impairment and blindness and affects 1 in 3 people with diabetes. And diabetic nephropathy occurs in 1 in 4 women and 1 in 5 men with type 2 diabetes. And in Australia, it's the #1 cause of end-stage kidney failure. So I just wanted to present a couple of brief cases just to demonstrate the importance of complication screening in people with type 2 diabetes. So the first case is Mr. PG, a 67-year-old gentleman who presents with 1 month of, a 1 month history of a painful red left big toe. His background history is of type 2 diabetes for over 15 years, hypertension. He had a history of smoking as much as 20 pack years history but had quit 20 years ago, and his exercise is only playing golf once or twice a week. His medications are metformin at 500 milligrams twice a day and ramipril for his hypertension. So he's examined by the GP, and his weight is 72 kilograms. He's of normal body mass index, and his blood pressure is satisfactory at 132/176. And on examination of his leg or the foot, particularly the left foot, the peripheral pulses are not palpable, and sensation is absent at the level of the ankles on both feet. And he has an infected ulcer of his left big toe. So he's referred to hospital due to concerns about osteomyelitis, and this is confirmed on MRI, and he's admitted for intravenous antibiotics and a big toe debridement. And blood tests show he's got poor glycemic control. His HbA1c is 10%, or 86 millimoles per mole. And a lower limb angiogram during his hospital admission demonstrates significant peripheral arterial disease. He's got extensive calcification and plaque through the major vessels, he has occlusions of his anterior and posterior tibial arteries, but a patent peroneal artery which is perfusing his ankle and foot, so he didn't require any angioplasty or stenting. So his progress in hospital is that regular blood glucose monitoring is started during the admission, and his medications for diabetes are increased. So his metformin dose is maximised to 1 gram BD, and a glycoside modified release formulation is added to his therapy. He's seen by a diabetes educator and agrees to restart some self-monitoring of blood glucose levels, given that he needs to improve control in the context of his active foot ulcer. And he's seen by a dietitian. His wife is there as well for the dietitian review, and they're planning to make significant changes to their diet. And he started on aspirin because of the peripheral arterial disease, and a statin at high dose because of the evidence of peripheral arterial disease and his high cardiovascular risk. So his foot wound demonstrates ongoing severe infection, and he subsequently has a big toe amputation. He's discharged, and at his 3-month follow-up, he continues to see the high-risk foot service for management of the foot wound that's healing, and his HbA1c has improved significantly from 10% to 5.2% just with optimizing his diet and increasing, basically just adding a second agent, which is the sulfonylurea. He has screening for diabetic retinopathy, and that's negative, and he has a normal microalbumin urine, a normal urine albumin-creatinine ratio and normal renal function. And he reports that his last cardiac assessment was many years ago. So once his foot wound has resolved, he is referred for a treadmill exercise stress test, and it's positive. And he goes for a coronary angiogram, and this shows triple vessel disease, and he's actually currently awaiting bypass surgery. So that's the first case that just demonstrates the importance of providing patients with education about foot care and prevention of ulceration, particularly in the context of neuropathy. And there's a lot of reasons why patients with diabetes develop foot ulcers. So there's clearly the neuropathy, but not just the fact that they can't feel things, but because they lose that proprioception, there's increased physical stresses and that on the foot, and that contributes to ulceration, and with vascular contributors and the autonomic component to it as well. So what I would really like you to all be comfortable with doing once you leave here, if you're not already doing some sort of foot screening or have a system to do so, is to utilise the 60-second foot screen for high-risk diabetic foot, and you should have a copy of the screen in your packs that you've been given tonight. There's just the 4 components to it. It's just taking a brief history, but the key thing is examining both feet and feeling pulses and testing for neuropathy with a monofilament. So just a reminder, your peripheral pulses that you'll want to feel for, if there's good circulation, you should be able to easily feel a posterior tibial pulse posterior to the medial malleolus, and a dorsalis pedis pulse just lateral to the extensor tendon for the big toe. So this is the 60-second foot check, which is taken from an article in PLOS One a few years ago, and it's basically this section that you need to just tick off when you do a foot check. So just to ask or determine if the patient's had a previous ulcer, you'll be able to see on examination if there's been any previous amputation and if there's any deformity. Also looking for things like an ingrown toenail, and if there is an active ulcer, and checking particularly between the fourth and fifth web spaces, and checking between the toes for any changes. Looking for blisters, calluses over the plantar surface of the feet, and any fissures, particularly on the heels. So if any of those are a yes, then that would be a positive screen. Finally, for neuropathy, for that to be a yes, you would check 10 different sites on the feet. So 9 different sites on the plantar surface and 1 spot over the dorsum of the foot, of each foot, to determine if there's presence or absence of sensation to monofilament. And if there's more than 4 absent sites, then that would be considered a yes for neuropathy, and that would be enough to be a positive test. So a positive screen is 1 or more yes responses for any of those things, and that would be an indication for you to be referring the patient to a podiatrist for prevention, treatment and follow-up, because of the increased risk of a foot ulcer and or infection in someone with diabetes if they have a yes response for any of those things. And it really does just take 60 seconds, so it should be something that, according to cycles of care, should be done twice a year. If it's a negative screen, then that's all you have to do at that point in time. You don't have to refer the patient, but the patient should be re-examined within 5-6 months. But it's a good opportunity to educate the patient about foot protection. And it's quite basic advice to give patients, but it's just to have that conversation so they're thinking about their feet, because they do take it for granted. And when they do develop, well, patients that I've seen that develop foot complications, they give you that response that, oh, I had no idea that this could happen. So it's simple things like maintaining good hygiene, advising them to inspect and wash their feet daily, to check for things like erythema, cracking, blisters or maceration, and to have a review if any of these develop. Encouraging good footwear to reduce pressure areas, such as wearing well-cushioned shoes, and avoiding walking barefoot is a key thing to encourage them to do, and if they're doing so, to check their feet at the end of the day. And ensuring patients who are elderly or visually impaired, or who aren't able to actually get down to their feet regularly, to ensure that you're advising their carers about foot care. So in cases where it's more complex and urgent, the indications for referring to Ian's service at Royal North Shore Hospital, the high risk foot service, is that they live in our LHD and have diabetes, and they either have an active foot ulcer, a foot infection, or neuroarthropathy, which is a Charcot joint. And this is just an example of what that looks like. And just to just go through what an acute Charcot foot is. So it's basically because of neuropathy in the feet, you develop, or patients with diabetes can develop, this chronic progressive destructive arthropathy. It is not common, so it occurs in about 1 to 2% of patients with diabetes, but the signs that you're looking for is a hot, red, swollen, painless foot generally, but if it can progress to the point where it does become mildly or intensely painful. And foot pulses can be present because it's to do with the neuropathy, not a vascular process. And it can often be misdiagnosed for things like a DVT or an infection or gout. And the late changes that you would see, and hopefully not see rather, is the rocker bottom change, where you get destruction of the joints in the foot and you get that appearance. So we'll move on to another case. This is Mrs. O.L. She's a 45-year-old female who presents with blurred vision in her right eye for 3 days associated with a mild headache. Her background history is only significant for gestational diabetes when she was pregnant at the age of 28, and postpartum she did a glucose tolerance test and that confirmed type 2 diabetes. She's a non-smoker and works as a seamstress, and her only medication is Diabex XR 500 milligrams at night, but she does admit that she misses her tablets some days. So on examination with her GP, her weight is 69 kilograms and she's overweight with a BMI of 29. Her blood pressure is above target at 148 on 96. Examining her eyes, there's no discharge or conjunctival injection. Her visual acuity is only 6 on 60 in the right eye, but is normal in the left eye. And her pupils are equal and reactive to light. Her visual fields are normal, and her eye movements are normal. So there's no cranial nerve palsy, which can occur with patients with diabetes. So she's referred to an optometrist and diagnosed to have a right retinal hemorrhage. And blood tests done by the GP show an HbA1c of 12.4% with normal renal function and liver function, and a fasting cholesterol high at 8.5. So she's sent to an ophthalmologist with the referral from the optometrist that then identifies that she has right-sided proliferative diabetic retinopathy with a vitreous hemorrhage and diabetic macular edema, which is something that you don't want your patient to have. And on the left side, where she had perfectly fine visual acuity, she does in fact have severe non-proliferative diabetic retinopathy, but it's not affecting her macula, so her acuity is fine. And she has treatment with pan-retinal photocoagulation or laser and VEGF injections to the right eye. With her medication management, her Diabex XR is increased to the maximum dose of 1 gram twice a day, and empagliflozin, an SGLT2 inhibitor, is started in addition to insulin to optimise her glucose levels in the context of this retinopathy and that poor control with an HbA1c above 12%. She sees a dietitian and works on making changes to her diet. She starts some exercise, and she started on a statin as well as with that high cholesterol level, and fenofibrate is added, and I'll talk about that more in a moment, and perindopril because of the hypertension. At her 3-month follow-up, she is still seeing ophthalmology regularly for treatment. Her blood pressure has improved with that dose of perindopril to 126 on 86. Her weight is not much different, she's lost half a kilo, but she's continuing her regular walks. Her HbA1c has improved, but it's still suboptimal, but it's 8.4%, and her lipid profile is good. So not in target, but it's better than an 8, with a fasting cholesterol of 4.9. She had an episode of thrush, so she actually stopped the empagliflozin herself, and her insulin doses need to be increased as a result to improve her glucose levels. She's unable to work as a seamstress because she can only see light versus dark in that left eye. So that case just emphasises a few things about patients with diabetes and the potential to be complacent about diabetes, because really it doesn't cause you any symptoms unless sugars are exceedingly high or if you develop complications. So for retinopathy, the duration of diabetes does tend to be the strongest risk factor for developing retinopathy, but having said that, you do have to screen from the time of diagnosis of type 2 diabetes, so it can occur at any time. Severe retinopathy, as we've seen in that case, can actually present with normal vision, as was the case in her left eye, which was not affected by hemorrhage, but it did have severe non-proliferative diabetic retinopathy. And regular screening can prevent visual loss. Apart from retinopathy to do with diabetes, cataracts are more common in diabetes and are seen at a younger age, and they progress more rapidly, so just to be aware of that. And with fluctuations in blood glucose levels, there can be changes in fluid shifts into and out of the lens of the eyes, so patients will report blurred vision, and that's why that's a characteristic symptom of a new diagnosis of diabetes, but it can occur with fluctuating sugars as well, so just to be aware of that. And if it's relevant to a patient that has pre-existing diabetes and falls pregnant, it's important for them to be monitored for progression of diabetic eye disease, which can definitely happen in pregnancy. So in terms of screening for diabetic eye disease, photography is required, so an optometrist referral is needed for screening. The other option is to see an ophthalmologist for screening, but optometrists do have a Medicare item number, so it can be potentially covered by Medicare for patients. So with type 1 diabetes, screening begins at 2 years after diagnosis or from puberty, and for type 2 diagnosis, for type 2 diabetes, screening should begin at the time of diagnosis, as I mentioned. In terms of how often should you be resending your patients or reminding them to be seeing their optometrist, so if someone has diabetes with no complications, good control and no evidence of retinopathy, then every 2 years is quite fine. And if they have long-standing diabetes or suboptimal control, then annually is more appropriate. And if there is identified diabetic retinopathy, then ongoing reviews might be every 3 to 6 months, and that should be with an ophthalmologist. So just to give you an idea of the different types of diabetic retinopathy, so there's non-proliferative diabetic retinopathy, which can be mild, moderate or severe, and that's where patients get retinal hemorrhages and exudates. And then there's proliferative, so there's neovascularization or new blood vessels, which sounds good, but it's not, because these blood vessels are more leaky and that leads to bleeding and loss of vision. And maculopathy or diabetic macular edema is when the retinopathy is overlying the macula and it's going to affect their centre of vision, and that's critical. So mild and moderate non-proliferative retinopathy are generally not treated unless they do involve the macula, but severe non-proliferative diabetic retinopathy is treated with laser because that will reduce the progression to proliferative. Proliferative diabetic retinopathy can be treated with laser as well, or if there's a big bleed into the posterior vitreous, then vitrectomy surgery is done. And diabetic macular edema is treated with anti-vascular endothelial growth factor injections, and patients will have multiple of those. So who would you refer to an ophthalmologist? So patients that have mild or moderate non-proliferative diabetic retinopathy should have a review with an ophthalmologist, but that does not need to be urgent. An urgent ophthalmology assessment is indicated if there's rapid visual deterioration, if there's severe non-proliferative retinopathy or proliferative diabetic retinopathy or diabetic macular edema, and that can be to a private ophthalmologist, or for our LHD there is the eye clinic at Royal North Shore Hospital, and to triage patients they do request that you send the letter from the optometrist with your referral to the eye clinic, otherwise there will be a delay. So what should you be telling patients about diabetic eye disease? So quite simple education for them would be that if they notice any visual symptoms, to seek attention early, and to be monitoring each eye by covering one eye at a time to keep track of if there is any change, and reinforcing that active management of their sugars, blood pressure and lipids will prevent the onset of retinopathy, but if they have retinopathy, it will reduce the progression of it. But also to keep in mind that if someone does have retinopathy and they are rapidly improving their glycemic control, which does often happen when people develop complications, that can actually sometimes in the short term worsen retinopathy. So if they notice a change in vision with their improvement in glucose control, you might actually want to refer them for a review at that time in case there is some progression. But in the longer term, the risk of retinopathy progression is significantly decreased by good glycemic control. So I wanted to just briefly mention fenofibrate in diabetic retinopathy, or Lipidyl. So it is thought to slow progression of retinopathy, particularly if it's in the mild or moderate non-proliferative stage. And the evidence we have for this isn't fantastic. It's evidence from the field and Accord studies where they were primary cardiovascular outcome studies, but retinopathy was looked at as a tertiary endpoint, and there was certainly evidence of a reduction in progression of retinopathy and the need for laser treatment. And in the field study, there's suggestion that it actually helps with all microvascular complications in diabetes. So in 2013, Australia actually became the first country to approve through TGA fenofibrate for diabetic retinopathy, but it is not PBS listed for the prevention or management of diabetic retinopathy. And the mechanism is not through, well, not just through improving lipids, because patients don't even need to have dyslipidemia to benefit from it in the context of retinopathy, but there are other mechanisms that it's thought to work through. So case 3, this is Miss AR. So she's a 62-year-old female who attends her GP to review her diabetes annual cycles of care. So she's had diabetes, type 2 diabetes for 8 years. She's got good glycemic control with an HbA1c of 6.8%. She does not smoke, and her diabetes is managed with Zinc Duo, so combination of metformin and the SGLT2 inhibitor dapagliflozin. Her weight is 65 kilograms and her BMI is okay at 24.2, and her blood pressure is good at 128/74. So she's attended her optometrist and she's got no evidence of diabetic retinopathy. You've performed her foot screen and it's normal, but her urine albumin creatinine ratio comes back elevated at 6.8, the normal being less than 3.5 for females, but her creatinine is normal with a normal eGFR. So what would you do next? Any comments? So just one positive urine albumin creatinine ratio.
Repeat that.
Repeat it? Yeah. So I wouldn't rely on just the one, particularly if it's not majorly elevated. So she has a midstream urine and she doesn't have evidence of a UTI, and her repeat urine albumin creatinine ratio comes back as 5.4, and a third one is still 5.5. So she has microalbuminuria. So urine albumin creatinine ratios are very useful compared to when we used to do 24-hour or 12-hour overnight collections of urine. It's just a spot urine collection. It doesn't have to be fasting, but so it's got nothing to do with what they've eaten or anything. And it doesn't matter if they've been drinking that morning, they just need to get a little bit of urine, and ideally the first pass though, if you want to exclude any, because there can be 50% variation essentially if you between a morning void and later in the day. So if that first one done whatever time of the day is positive, you would want them to do a morning one. The cutoff is 2.5 to 25 for men as microalbuminuria, and above 25 would be technically macroalbuminuria, and for females 3.5 to 35. So it should be confirmed with 2 additional specimens collected over the next 3 to 6 months. However, if it's significantly elevated, it's unlikely that it's going to come back normal, so you wouldn't want to delay further investigations, specifically the renal function testing, if it's significantly positive. So there are a few things that do influence urine albumin creatinine ratios, so particularly a urinary tract infection, so you might want to exclude that. High dietary protein intake, heart failure, a febrile illness, heavy exercise, menstruation and vaginal discharge in women, and non-steroidals. But I guess if you're checking it over the 3 to 6 months period, then it's pretty reliable. So I just wanted to show you this diagram because we often forget that chronic kidney disease stage 1 is actually normal renal function in the presence of microalbuminuria, and so that's stage 1 in that first row. And basically if someone has microalbuminuria, they're already in this yellow zone, which is a moderately increased risk associated with chronic kidney disease. So it should start alerting you to, and the patient should be aware that they don't want this to progress if they can try and address other risk factors and try and prevent progression. So what would you do for the patient? You'd be aiming for target blood pressure under 130/80, and the lower limit of how much you want to lower their blood pressure is not clearly defined, but definitely under that target. And using an ACE inhibitor or ARB should be the priority, and ARBs are as efficacious and safe as ACE inhibitors. So both classes do reduce the risk of doubling of creatinine, reduces progression of micro to macroalbuminuria, and increases the rates of regression from microalbuminuria to normoalbuminuria. So you can tell the patient that if we optimize your blood pressure, this protein in your urine might disappear, and it can remain that way if they remain on their ACE inhibitor or ARB. So I wanted to just touch on medications we use for diabetes that you have to think about in renal impairment. So the obvious one is metformin because of the risk of lactic acidosis. So if a patient has normal renal function, you would use up to the maximum of 2 grams of a daily dose, but if their EGFR is 30 to 45, you would use up to 1 gram per day, and I would suggest stopping metformin if their EGFR is under 30. With sulfonylureas, they are going to accumulate in the presence of renal impairments and therefore increase the risk of hypoglycemia, so you want to be careful with them. It doesn't mean not to use them, but just be careful, particularly with the modified release versions. DPP-4 inhibitors, linagliptin doesn't require any dose adjustment in the presence of renal impairment, but the others do, and they can all be used except for saxagliptin in end-stage renal failure. So they're a good option in patients with renal impairment. SGLT2 inhibitors, so essentially they work by blocking the SGLT2 receptor and therefore promoting glycosuria as the mechanism of reducing sugars, so you need renal function for them to work. So dapagliflozin would only be used if EGFR is above 60 and empagliflozin if EGFR is above 45. GLP-1 receptor agonists, so that's your Byetta, Saxenda, Victoza, Bydureon weekly, so they're not recommended if EGFR is less than 30. Insulin is a good option in renal impairment, but you just need to think about reducing doses because of the risk of hypoglycemia. So when would you refer your patient for a renal specialist review? So you would send them for a non-urgent renal review if they have stage 4 or 5 chronic kidney disease. So that's an EGFR under 30. If there's persisting macroalbuminuria, if they've got hypertension that's not at target despite using at least 3 antihypertensives, or if they've got a sustained decrease in their EGFR. And an urgent review would be appropriate if there's a rapid decline in EGFR or if there's signs of acute nephritis, and that would be to a private renal physician or the kidney clinic at Royal North Shore Hospital. So what I'll do is just give me a second. So can I just ask how many practices or how many of you are familiar with the Practice Incentive Program for diabetes and utilising it? Okay, so hopefully after this everyone will be. Just a moment. Okay. So I won't worry about showing you the details, but basically that link on this page will, or essentially you could Google the Practice Incentive Program for Diabetes, which is available for a lot of chronic diseases, and diabetes is a good one. So basically there's 3 components to it. You get a sign-on payment according to your standardised whole patient equivalent. You get an outcomes payment according to completing the diabetes cycle of care for at least 50% of your patients with diabetes, and there's a service incentive payment according to completion of a cycle of care per patient. So this is basically what you would be wanting to, or what you would need to be achieving each 12-month period for your patients with diabetes. So it's doing an HbA1c at least once a year, but really it's covered by Medicare every 3 months. So it would be good to know more frequently than once a year how your patient's going with their glycemic control. Having an eye review once every 2 years is what it specifies here. Having a weight and BMI checked twice a year, having blood pressure and feet checked twice a year, so you would use that 60-second foot check and that would be covered. Having lipids checked once a year and urine albumin creatinine ratio and renal function once a year, and providing the patient with some education on diet and exercise, and encouraging them to stop smoking if they do. And to review patients' medications is the last item there, which you can't see. But I just wanted to touch on medications review in type 2 diabetes. So just quickly, anti-hypoglycemic agents, there's a lot to talk about and a lot available for you to use or to prescribe for your patients. This is a fantastic website developed by the Australian Diabetes Society, which provides a guide, which is just clicking through a potential treatment plan for patients and giving you all the options that are available for managing diabetes, and provides a few case studies as well. And when you would use which agent, so it's quite good. This is the treatment algorithm that's been developed by the ADS, which looks cumbersome, but essentially the blue boxes are recommended or standard first line, second line, third line treatment options, and in the red boxes are what would be PBS subsidised. In terms of other medications that you want to think about in your patients with type 2 diabetes, one is aspirin. So in primary prevention, so that is patients with type 2 diabetes that have risk factors of cardiovascular disease but have not had any evidence of cardiovascular disease, aspirin is not usually recommended. The benefits of daily aspirin is still uncertain. In a meta-analysis of 10 trials evaluating aspirin for primary prevention of cardiovascular disease, it did not significantly reduce the risk of any individual endpoints such as myocardial infarction and stroke or all-cause mortality. It did have a modest but significant p-value for the risk of major cardiovascular events, but the relative risk was 0.9. So it's up to you to determine whether that's significant enough for your patients, and keeping in mind that there is that risk of bleeding, particularly catastrophic GI bleeding that can arise. But secondary prevention, so if someone has evidence of cardiovascular disease that's been diagnosed, it is clear that they should be on aspirin. If they don't tolerate aspirin, then it's generally clopidogrel, depending on what their problem is. And so if there's a history of ischemic stroke, not hemorrhagic, or ischemic heart disease or peripheral arterial disease. And finally, just so before we talk about antihypertensive briefly, just statins. So patients with type 2 diabetes and any known cardiovascular disease, so that's ischemic heart disease, peripheral arterial disease, or ischemic stroke, should be receiving the maximum tolerated dose of a statin, irrespective of their lipid levels. And keeping in mind that patients with type 2 diabetes and microalbuminuria, with nothing else, are considered to be at high cardiovascular disease risk, and they are entitled through the PBS to be on a statin. But for everyone else with type 2 diabetes, you would use lipid-lowering agents to get them to target, and that's a total cholesterol of less than 4, an LDL less than 2, and a triglyceride less than 2. Keep in mind that hypertriglyceridemia can be seen when glucose levels are poorly controlled. So if triglycerides are persistently high, in the context of poor glycemic control, you can use the non-HDL and aim for less than 2.5. And then finally, in terms of medications, antihypertensives in type 2 diabetes. So the first line therapy should be an ACE or an ARB, and if that's not sufficient, then there's grade B evidence for a calcium channel blocker and grade C evidence for using a thiazide. And if I can finally just touch on quickly the fact that it's not in your cycles of care, but it's really important to be discussing with patients and using their cardiovascular disease risk as a motivating factor, perhaps for encouraging them to get to target with their risk factors, so blood pressure and lipid management. And any patient with type 2 diabetes that's over 60 is at high risk of cardiovascular disease, or as I said, if they have microalbuminuria. For all the other patients with type 2 and are under 60 and have a normal urine albumin-creatinine ratio, then you should be measuring their cardiovascular risk using, for example, the Framingham risk evaluation, which can be accessed through that website. And so you may or may not be familiar with the risk calculator, which is a fantastic tool to estimate their 5-year risk of developing having a cardiovascular event. And it provides a guide as to what you should be doing, which is really just addressing their risk factors, so blood pressure, getting that to target, getting lipids to target, which I just told you what the targets were for type 2 diabetes, advising them and encouraging them to stop smoking, and then diet and exercise. It can also be a useful tool to guide when you're going to refer a patient to see a cardiologist or refer them for cardiac testing. And that's all I wanted to talk about.